My name is Ashley Anderson, a student at the University of Memphis, coming to you today to present a case study on congestive heart failure. The purpose of this presentation is to define the pathophysiology of congestive heart failure, present a flow chart of congestive heart failure, and discuss the treatment options based on best practice. In addition to discussing the pathophysiology of congestive heart failure, we will also explore best practice considerations, evidence, and treatment options that directly relate to the pathophysiology. Today we'll be talking about a patient named David. David is a 66-year-old African-American male that called 911 and was found to be short of breath. He reported shortness of breath over 3 days, but on the evening he called 911. His shortness of breath was worsening and he couldn't even lie down. So he got concerned and he called 911. When they arrived, he was very tachypnic, very out of breath, and they placed him on a CPAP machine en route to the hospital. They report they gave him 2 breathing treatments, and they also gave him some Solumedrol and magnesium en route. When he got to the ED, he did report he was already feeling a lot better, and he was placed on BiPAP by the emergency room staff. He complains of occasional chest pain, but is currently not having any. He is a pack per day smoker, also has a history of COPD. Last echo in the chart was about 2 years ago, and at that time his ejection fraction was 36 to 40%. He currently denies any recreational drug use. However, he has been positive for cocaine in the past via urine drug screen. Patient is a full code and alert and oriented. David does have a fairly significant past medical history. He has COPD, a noted history of congestive heart failure, chronic kidney disease that he does not require dialysis for at this time, hypertension. He has had a fairly recent MI that required heart cath with a stent placed to the RCA. He did have coronavirus last year, has suffered from atrial fib in the past, and as we discussed earlier, a history of cocaine abuse. David does take several medications at home, and he reports that he takes them as prescribed. Important ones to his history and his presentation, he takes carvedilol, Entresto, furosemide, and he's on several inhalers. However, when the pharmacy technician called to verify his medication list, the pharmacy does report that he has not had several medications filled in several months, including his carvedilol, Entresto, and furosemide, which could be a reason why he has presented to the emergency room at this time with the symptoms that he is having. On physical exam, David is afebrile with a temp of 36.8. He does have increased respirations of 26. However, that is down. EMS reports in the 40s when they arrived to pick him up. So that has improved. His blood pressure is still elevated at 172 over 96, but there will be medicine orders placed for that. His heart rate is 109, so he is a little tachycardic. He has noted PVCs, but he is in a normal rhythm, which is important because he does have a history of AFib. His oxygen saturation is fine at the moment, 98%. He is currently on BiPAP. Upon respiratory assessment, he is mildly in distress. crackles are heard in bilateral lower lobes, and he does have an intermittent non-productive cough. Um, he does have an S3 gallop heard on his cardiac exam, but there's no JVD or any other noted abnormalities. Neuro is intact. He's alert, awake, and oriented. David was given 60 milligrams of Lasix. His breathing did get better, and he did have a good response with urine output to that. So at this time, David is showing some improvement in his symptoms. When David arrived to the ER, an EKG was performed. He did show tachycardia with PVCs and an old septal infarct. The EKG is typically ordered to determine if the patient is having any type of acute cardiac event that can be treated. David did report he has occasional chest pain, although he's not currently having any. And it's also a good idea to rule out any abnormal rhythms or ischemia. But his EKG looks to be okay. And they also performed a chest x-ray, which is routine with the way he presented to the ER with his respiratory distress. That can be used to rule out any other diagnosis that he may have, even though he does have history of heart failure and COPD. They are often ordered chest x-rays to determine the size of the patient's heart and can possibly assess for any pulmonary fluid collection or if he does have any other lung issues going on. Echocardiograms are frequently ordered if there's not a recent one. His last one was in about 2 years ago. So this is a first choice clinicians use in regards to heart failure, so they can follow the disease progression and kind of determine how bad the heart failure is. A normal ejection fraction is between 50 and 70%. David's is 30 to 35%. And that places him in the category of heart failure with reduced ejection fraction because his is less than 40. There is another category of heart failure with a borderline EF, which is 41 to 49. Patients can also have heart failure with preserved ejection fraction. That would be anything greater than or equal to 50%. This slide is just to show an example of what a normal chest x-ray would look like, which is on the left. And the one on the right is a patient that is in heart failure. You can see the increased whitening area around the heart, and it does look like the heart may be a little enlarged. This is just another good picture I found that kind of further explains ejection fraction. The ejection fraction does compare the amount of blood in the heart to the amount of blood being pumped out. And that's how they get the number. And then it just has a nice picture showing the normal, borderline, and reduced, just a better visual picture of what we were just discussing. David did have several labs drawn. Most are pretty basic labs. They did have a complete blood count drawn, a basic metabolic panel. He did have a troponin series, pro-BNP urinalysis. They did check for a urine drug panel just due to his history, but that was negative. Blood gases were normal. They did those because he was in such respiratory distress. His lactic acid levels were elevated, and they checked the liver function test. Uh, Sometimes heart failure can have an effect on the liver. David's potassium was a little bit low. Normal is 3.5 to 5. His was 3.4. This is likely due to his use of diuretics at home. He also does have history of kidney failure. He could be a little dehydrated, which is probably the same reason his creatinine is elevated at 1.67, which isn't too far from normal, and uh, with comparison, that is likely a normal creatinine for him with him having kidney failure. His lactic acid is elevated, likely due to the heart's inability to deliver the right amount of oxygen to the metabolizing tissues. Um, Hopefully that will come down after treatment. His BNP, pro-BNP was 8,543. With patients of known heart failure, they needs to be less than 900. So his is quite elevated. This is due to the myocardial wall stress. The natriuretic peptides are secreted into the blood in response, and that is why his are elevated. He has been diagnosed to be in an acute congestive heart failure event, which is why that is elevated. Since David has been diagnosed with congestive heart failure, let's discuss what congestive heart failure is. It's basically the heart muscle is not pumping blood in the manner that it should, which causes fluid to back up into the lungs and legs, feet, the rest of the body. Congestive heart failure is a complicated syndrome where the heart's ability to fill the ventricles with blood or the ability to eject blood is impaired. It does not mean that the heart has completely failed and stopped working. It just is not working as efficiently as it should. This could be from structural or functional abnormalities, as well as other triggering factors that can cause this to happen. This disorder does have a very high mortality rate and affects an estimated 26 million people across the world. The pathophysiology of heart failure, the book defined it as a condition where the heart is not able to produce a sufficient cardiac output, causing inadequate perfusion of tissues and or an increase in diastolic filling pressure. This causes pulmonary capillary pressures to increase. Basically, it starts when the heart is damaged, usually by either coronary artery disease or by hypertension. Hypertension causes narrowed arteries and an increased afterload. The damage and weakened heart causes a decrease in stroke volume. Stroke volume is the amount of blood that is pumped out of the heart with each beat. And with the decrease in stroke volume, this causes a decrease in cardiac output. And cardiac output is the amount of blood pumped out by the heart each minute. So when this happens, the body attempts to compensate by increasing the heart rate. But when that happens, the heart has less time to fill properly. So the body also attempts to compensate and increase the stroke volume by something called dilated cardiomyopathy. This is where the ventricle wall becomes thin in an effort to help, but in return, the heart becomes weaker by trying to become bigger to compensate. Also, the ventricle may also become thicker, which is hypertrophic cardiomyopathy. This causes stiffness of the walls and an inability to fill properly. So it's like all this is causing just one thing after another, just a big cycle. And while all that's happening, it starts affecting the kidneys. And then kidneys have a lack of blood and they begin to retain fluid. When the kidneys start not working properly, they release renin and angiotensin hormone, which then releases aldosterone, causing salt and water retention. When this cycle continues, this causes fluid overload. In addition to the hemodynamic effects, heart failure also affects other systems in the body, inflammatory, metabolic processes, and neurohumoral. The first one is catecholamines are stimulated by the sympathetic nervous system. They do this in attempt to compensate for the decreased cardiac output. But over time, they cause toxicity to myocytes and facilitate in dysrhythmias and become unable to improve contractility. Also, the ROS is activated and causes an increase in preload and afterload, decreases contractility and ventricular contractility, dilation. Aldosterone also, again, causes salt and water retention. Arginine vasopressin causes peripheral vasoconstriction and renal fluid retention. Natriuretic peptide increases to help decrease the preload, but not enough to truly help with heart failure. Inflammatory cytokines are increased and associate with poor prognosis and further deterioration. Myocyte calcium transport in and out of the cell have been connected to decreased myocardial contractility. And diabetes leads to a decreased myocardial contractility and remodeling. In this picture, one type of congestive heart failure, the one that David has, is congestive heart failure with a reduced ejection fraction, because his EF is less than 40%. And as we said earlier, this is calculated by an echocardiogram. To determine the cardiac output, you must determine the heart rate and the stroke volume. The stroke volume is determined by the contractility, the preload, and the afterload. Then this causes ventricular remodeling, which is the disruption of normal myocardial structure, results in dilation of the myocardium, and progressive myocyte contractile dysfunction. So when the contractility decreases, stroke volume decreases, left ventricular and diastolic volume increases, and dilation of the heart and increase in preload. So there are two types of heart failure: left-sided heart failure and right-sided heart failure. Left-sided heart failure causes blood to back up to the left side of the heart, which is the left ventricle and the left atrium, and then while it's backing up, it goes into the lungs. It seeps into the tissues or to the lungs, causing pulmonary edema, which is congested, where you get the word congestive heart failure, congestion of the lungs. Symptoms of left-sided heart failure include nocturnal shortness of breath, restlessness, confusion, tachycardia, fatigue, cyanosis, cough, wheeze, blood-tinged sputum, and tachypnea. Typically, you see right heart failure with left heart failure, but sometimes you can see right heart failure on its own, but usually right heart failure is caused from left heart failure. So right-sided heart failure is the blood is trying to get into the right side of the heart, the right ventricle and the right atrium. And the symptoms of that, backing up, because it's backing up from the brain, would be jugular vein distension. It backs up and causes peripheral edema, which that includes swollen ankles, ascites, swollen liver, swollen legs. Also causes fatigue, enlarged liver or spleen, weight gain, and GI distress. Well, these are the reasons why all those labs were checked on David earlier, including his liver panel, just to make sure his liver was not involved. And this picture is just another good, better visual of all of this. I'm a visual learner, and this is easier for me to look at. To better treat symptoms and for clinicians, heart failure has been broken down and placed into 4 different classes. This just makes it easier to diagnose and manage this progressive disease. The first class, really, as the picture shows, the patient is having very mild symptoms, but they are not directly affected by their daily activities. Just a little tired and breathless with a jog, nothing super major, just the beginning stages. This may also be called pre-heart failure. People with high risk factors such as diabetes, high blood pressure, coronary artery disease, and metabolic syndrome are placed in this class. With class 2, patients complain of becoming breathless or have elevated heart rate with moderate effort, such as walking. This does slightly restrict daily activity. They are still considered pre-heart failure, but at this point may have suffered from a lower ejection fraction or a previous MI. Class 3 patients become tired and short of breath with simple daily tasks. Their physical activity is markedly limited. They suffer from underlying heart disease affecting the pumping ability of the heart. Class 4 is when the disease has become advanced. The patient has significant symptoms of dyspnea, tiredness, cough, cognitive changes, and swelling. At this point, the disease process, the patient is very debilitated and unable to perform day-to-day tasks. At this stage, the patient requires more specialized interventions. With these classes, a person can move back and forth through them. Like if a person is considered in a higher class while they are experiencing a exacerbation episode, and then they can go back down to a lower class once they are better. The goal is only to delay progression as long as possible. This just is a slide that shows some of the symptoms of an acute exacerbation in patients with reduced EF. Due to inadequate perfusion of systemic circulation and pulmonary congestion, patients may experience, like I said earlier, a cough with frothy sputum, shortness of breath, decreased urine output, edema, and fatigue. And a physical exam often shows crackles in the lungs, hypo or hypertension, and an S3 gallop. Some of the complications of congestive heart failure include kidney failure, heart valve dysfunctions, heart arrhythmias, cardiac cachexia, stroke, pulmonary edema, and even death. Here are some of the contributing factors, and there are ways that you can try to slow the progression of the disease or prevent it from happening. Everyone should make sure they see their general practitioner for a heart health checkup, follow a heart healthy eating diet. Exercise is very important. Of course, no smoking. It's better to not even start smoking. Maintain a healthy weight, decrease alcohol intake and stress, keep cholesterol under control. Very important to manage blood pressure and blood sugar. Some of the risk factors for heart failure that are non-modifiable is age greater than 65. The older people get, the more at risk they are for developing heart failure. family history of heart disease or diabetes, other hypertension, things that can lead to coronary artery disease, which leads to heart failure, and heart issues are more prevalent in males. Modifiable risk factors is, again, smoking. Don't start and stop as soon as you can. Hypertension, obesity, diabetes, heart arrhythmias, coronary artery disease, and diet. David's biggest noted risk factor is his MI that he had. Coronary artery disease is one of the leading causes of heart failure. Heart failure after an MI is a very, unfortunately, common occurrence. It happens due to a combination of events: myocardial stunning, myocyte necrosis, decompensation of heart failure that was pre-existing, or mitral regurgitation. So this places David more at risk for developing heart failure. David also has, in addition to the coronary artery disease and MI, he had AFib, uncontrolled hypertension. He is a pack per day smoker and has heavy alcohol use. So this slide discusses David's heart failure. His non-modifiable risk factors is his age, because he is 66. He is a male, and he did have family history of CAD, and other family members have had heart attacks. So this places him more at risk for developing heart failure. And we already discussed his history and why that places him at risk, and his smoking. Smoking causes an elevation in blood pressure and vascular resistance, pulmonary artery resistance as well. It also causes impaired mitochondrial function, inflammation, impaired endothelial function, and worsening renal function. And it also affects the kidneys. His atrial fib could cause damage to his heart muscle further over time. However, David was currently in a normal rhythm. Hopefully he's taking his medications as he should. Hypertension, he causes the heart to work and pump harder, leading to the left ventricle becoming thickened, which can lead to heart disease and heart failure. He does have alcohol abuse, which weakens the heart muscle and the ability to pump appropriately. He also suffers from COPD, which weakens the heart, right chamber, and ventricle, and leads to right heart failure. The best way to prevent heart failure and/or control symptoms is to avoid contributing factors. The best thing a patient can do is to not start smoking, but if he already has, then stop immediately. Smoking is the leading cause of atrial damage, which is also a leading cause of heart failure. Maintaining a heart-healthy diet is another important prevention factor. Examples of heart-healthy food are leafy green vegetables, low salt, grilled or baked lean meats, and avoidance of fried and greasy foods. Exercise and weight management are important in maintaining a healthy heart. This can help prevent coronary artery disease and hypertension, which are both contributors of heart failure. Patients who suffer from multiple comorbidities are encouraged to stay on top of their treatment plan as prescribed by their physician. An example would be a patient with diabetes. It is important to keep blood sugar under control, as some patients can develop diabetic cardiomyopathy, which leads to heart failure. The goal of treatment of heart failure, there's currently no cure, so the goal is to improve the quality of life for the patient and to manage symptoms. Also, to decrease overall hospitalization stays and mortality that is related to this disease. Goals of therapy are to interrupt the worsening cycle of decreased contractility, increase preload, increase afterload, and block neurohormonal mediators that cause toxicity. There's pharmacological therapy is the best treatment found for heart failure, and in combination drug therapies are better and more successful than monotherapy from just a single agent. Often heart failure patients use a combination of drug therapies, diuretics, renin-angiotensin symptom inhibitors, angiotensin converting enzyme inhibitors, angiotensin II receptor blockers, and beta blockers. Other treatment options may need to be utilized for heart failure when modifiable risk factors and pharmacological risk factors are no longer the only option for these patients. For primary prevention of sudden cardiac death, an implantable cardiodefibrillator may be inserted. Patients with a left ventricular EF of less than or equal to 35% and an NYHA class of 2 to 3 while they're on appropriate medication therapies are candidates for this. The second one is a cardiac resynchronization therapy, CRT, with biventricular pacing. Is recommended for heart failure patients with a reduced EF of less than or equal to 35% and a QRS duration of greater than 150. They have seen potential harm when patients had a QRS duration of less than 130. When pharmacological therapy has been optimized, the use of intravenous medications may be needed. These are utilized to treat symptoms palliatively when patients are in stage in the disease process. Patients may be considered for heart transplants that have progressive heart failure or severe refractory heart failure. So, in summary, for David's treatment, David, while he is doing a little bit better, he will be admitted to the hospital for treatment and be treated with the bilevel positive airway pressure, the BiPAP machine. This will help his shortness of breath and give his heart a little bit of a break to kind of recover and reduces the preload. This will only be used temporary for a few hours. The goal will be for him to wean to just a regular nasal cannula, and then the goal is for him to get back to his baseline room air status. He will also be given furosemide IV as a diuretic to help pull fluid and reduce the preload. If David continues to respond well to the Lasix, he will do this for a day or two and be switched back to oral furosemide and tapered back down to his home dose. Due to David's continued elevated blood pressure, he was given nitroglycerin, which is a vasodilator and helps with preload reduction. David is responding well with this treatment plan, so the use of inotropes is not warranted at this time. David will be thoroughly educated during this hospital stay about smoking cessation. He will be started on nicotine patches daily. He was also educated on the need to decrease his alcohol consumption. David will need further education to ensure he is taking his meds as prescribed, eating a heart-healthy diet, and he has a scale at home to weigh himself daily to watch for signs and symptoms of fluid overload. At discharge, David will need to follow up with his primary care provider and his cardiologist to ensure his heart failure is being properly taken care of.